The hospital had seen her 4 times in 14 months. 4 times she arrived with injuries. 4 times the staff documented what they saw. 4 times they asked her how it happened. 4 times they recorded her answer in her file. Not once did anyone call the number that was printed on a laminated card attached to every examination room wall, the number for the domestic violence reporting hotline. It was there. They could see it from where they were standing. They chose not to call. Her name was Amara Osei. She was 31 years old. A registered nurse by training and temperament. She had spent 6 years working in the pediatric ward of the same hospital system that would later be scrutinized for missing every opportunity to intervene. Colleagues remember her voice in hallways, the way she learned children's names, the small kindnesses she extended without fanfare. In performance reviews, she was called an exceptional clinician, a steady presence in a demanding environment. Yet outside the ward, she lived with a pattern of control and violence that escalated over time. Her husband, Victor Osei, worked as a financial analyst. A forensic psychologist later described his behavior as coercive control, isolating her from family, seizing financial autonomy, monitoring her communication, and progressively increasing physical assaults. Those patterns, often invisible in isolation, together form a well-documented pathway toward lethal harm. 14 months before her death, Amara presented to the emergency department with a fractured wrist. She told the attending physician she had fallen down a staircase. The physician recorded the injury and the stated cause. Hospital policy required a mandatory reporting assessment when injuries suggested possible domestic violence. A young woman with a wrist fracture and no plausible history of falls met that threshold. The assessment was not completed. No domestic violence liaison was consulted. She returned home. 9 months before she died, she came back with 2 broken ribs and bruising across her left shoulder consistent with blunt force. She told a nurse she had been in a car accident. There was no police report, no insurance claim, and no independent record of a collision that day. The nurse documented the injuries and the explained cause. Again, the mandatory assessment was not used. The liaison was not contacted. Amara left without intervention. 5 months before her death, she arrived with an orbital fracture and lacerations to her left cheekbone. A senior emergency physician, 19 years into practice, examined her and noted in his chart that the stated cause, walking into an open cabinet door, was inconsistent with the injury pattern. He wrote the word inconsistent. He did not complete the reporting tool. He did not summon the liaison. He did not notify law enforcement. He discharged her. 6 weeks before her death, she presented with a dislocated shoulder and bruising to her neck. The intake nurse, recognizing her from prior visits, flagged the file for the hospital's domestic violence liaison. The liaison scheduled a follow-up assessment for the following week. Amara was discharged before that assessment occurred. The appointment was never rescheduled. 6 weeks later, at 6:42 a.m., emergency services received a call. A report that a woman had fallen down the stairs. The first officer at the scene noted that the injury pattern did not match a fall. A homicide unit responded. Victor Osei was arrested the same afternoon, charged with first-degree murder. 18 months later, a jury convicted him, and he received life without parole. The subsequent institutional response unfolded along familiar lines. An internal review found that established protocols had not been followed and identified gaps in training on domestic violence recognition and mandatory reporting procedures. The hospital announced comprehensive staff training, appointed a dedicated response coordinator, and released a statement expressing sorrow and commitment to change. Yet the institution's corrective measures did not include individual disciplinary action against the clinicians who had failed to complete required assessments during Amara's first 3 visits. Legal counsel advised that naming individuals could increase liability in civil proceedings. The internal review framed the problem as systemic rather than personal. The nurse who had flagged the 4th visit and initiated the referral, the one procedural success, was commended for following protocol, even as the follow-up never occurred. Amara's death, the conviction that followed, and the hospital's public promises illuminate an uncomfortable truth. Systems can carry policies, laminated cards, and forms while simultaneously allowing inaction to persist at critical moments. Each missed assessment, each unanswered flag, each assumption that a stated explanation sufficed, accumulated until it was too late. At sentencing, Amara's mother spoke with restrained grief and precise indignation. She described a daughter who had spent years caring for other people's children, remembering names, staying late, offering comfort in crises. She said there was a laminated card on every wall of those exam rooms. The number for help was printed on it. She asked, simply, for someone to explain why no one called. No one explained it to her. 4 visits, 14 months, a fractured wrist, 2 broken ribs, an orbital fracture, a dislocated shoulder. The word inconsistent written in a medical file by a doctor, who then sent her home. The laminated card was on the wall. The number was printed on it. Nobody called. Subscribe to Case Files TV. Every week, the cases the headlines covered, and the ones where the system saw everything and did nothing.